Hello, my name is Brett Houston, and I'd like to thank the organizers of ISICEM for the opportunity to give this talk. I'm a hematologist from Winnipeg, Canada, with a research interest in bleeding and transfusion in acute care. Today, we're going to review thrombocytopenia and critical illness. I'd like to start by thanking Ryan Zarychanski for putting these slides together. This topic was recently reviewed at the American Society of Hematology meeting, and an article summary can be found on their website for those who may be interested in further detail. So we're going to start by characterizing the mechanisms that contribute to thrombocytopenia in the ICU setting. We're then going to discuss the expected platelet counts in patients with septic shock and evaluate the platelet count trajectories and how this can be used to establish a diagnosis and inform prognosis. And then lastly, we're going to review common recommendations for platelet transfusion thresholds. The prevalence of thrombocytopenia at ICU admission varies widely, but can affect up to 2/3 of patients. Almost 50% of patients develop thrombocytopenia during their ICU admission. This variability reflects variation in the patient population, ICU characteristics, and the definition of thrombocytopenia used. Risk factors for thrombocytopenia are largely related to severity of illness and can include organ dysfunction, renal failure, vasopressor use, and sepsis. As expected, bleeding and transfusion are the major consequences of thrombocytopenia. This has been borne out in both observational and randomized studies such as the PROTECT trial. Thrombocytopenia has also been associated with increased mortality in critically ill patients. However, deaths are typically not due to bleeding. While the thrombocytopenia may independently contribute to poor prognosis, it's also possible that it serves as a marker of severe illness. Common causes of thrombocytopenia in the ICU include sepsis, DIC, consumption, dilution, and myelosuppressive chemotherapy. Less common but important causes of thrombocytopenia include HIT and HLH. In the PROTECT trial, the incidence of HIT was 0.6% in unfractionated heparin arm and 0.3% in the dalteparin-treated arm. While not common, certainly something that we don't want to miss. Hemophagocytic syndrome is an evolving entity with nonspecific presentation that largely overlaps with critical illness. Overall, HLH is not a common cause of thrombocytopenia in the ICU. I wanted to highlight a few uncommon causes of thrombocytopenia. Non-heparin-related drug-induced thrombocytopenia is often discussed, but is rarely the cause of thrombocytopenia in critically ill patients. For example, vancomycin is often referenced as a common cause of thrombocytopenia, yet in a major American referral lab, only 34 cases of vancomycin antibody-dependent thrombocytopenia were confirmed over a 5-year period. Leukemia, MDS, aplastic anemia, and other related conditions are unlikely explanations unless these abnormalities were present prior to the patient's ICU admission. We never want to miss TTP, but statistically it's very unlikely to develop in the ICU when there's an alternative diagnosis. And ITP and PTP are also uncommon in this setting. Given how often we discuss drugs and their propensity to cause thrombocytopenia, I wanted to highlight a few features. So drug-induced thrombocytopenia typically takes a week to develop, and it's characteristically severe, with platelet counts that nadir in the less than 20 range. While uncommon overall, the drugs most commonly associated with thrombocytopenia include antibiotics, chemotherapy, 2B3 inhibitors, and anti-seizure medications. Unfortunately, the mechanisms of thrombocytopenia in critically ill patients are poorly understood, and the cause is often multifactorial. Few tools exist to understand the underlying pathophysiologic process. In contrast to typical hematology teaching, decreased production and sequestration are rarely explanations in the ICU setting. In fact, inflammatory cytokines stimulate thrombopoiesis, which you'd expect to result in a thrombocytosis, if anything. The bulk of thrombocytopenia in the ICU is related to destruction or increased consumption of platelets, and this can occur for a variety of mechanisms that are highlighted here. Sepsis is a common cause of thrombocytopenia and may result in approximately 50% of thrombocytopenia in the ICU. Colleagues of mine recently completed a retrospective cohort study of thrombocytopenia in sepsis, and they found that nearly 50% of patients were thrombocytopenic. The median time to thrombocytopenia was 2 days, with an average duration of nearly 1 week. In patients who survived, the average nadir was approximately 60. Consistent with prior literature, we also found that thrombocytopenia is associated with increased ICU length of stay, duration of organ support, bleeding, and transfusion. We found that thrombocytopenia is associated with increased hospital mortality, the risk of which is paralleled by the severity of the thrombocytopenia. Perhaps most notably, we found that the recovery of thrombocytopenia lags behind liberation from vasopressors by 2 days. This can inform expectations regarding the delayed recovery and the need for further investigations. While we don't have time to elaborate further in this talk, the mechanisms of thrombocytopenia can inform therapeutic trials in the critically ill population, including but not limited to heparin, IVIG, plasmapheresis, and complement inhibitors. So how do I approach thrombocytopenia? I find it easiest to organize by lumping into past and present. Relevant historical features include the overall clinical context and the presence of prior thrombocytopenia. Notable features that can help distinguish etiologies of thrombocytopenia include the trajectory of the platelet count, severity of the thrombocytopenia, and the presence of thrombosis. Pattern recognition of common platelet trajectories can be very informative when trying to identify the cause of thrombocytopenia. When the platelet count presents low and stays low, this suggests an independent cause of thrombocytopenia, such as a pre-existing condition, possible marrow failure, hypersplenism. Investigations could include assessment of the spleen size, review of the peripheral blood film, and a bone marrow evaluation. When the platelet count falls immediately and recovers quickly, this is characteristically seen in major surgery, particularly patients who've recently underwent cardiopulmonary bypass or in patients who were treated with massive transfusion. When the platelet count falls in the first few days and recovers with improvement of the clinical condition, this is often seen in patients with sepsis, multi-organ dysfunction, pancreatitis, or burns. When the platelet count falls and stays low in a patient whose clinical course is otherwise recovering, this is when I would consider iatrogenic causes. So this is when I'd send a HIT assay, I would look for other drugs that could be potentially related, and rarely consider things such as post-transfusion purpura or PTP. And lastly, when the platelet count falls within the first few days, it stays low in a patient with persistent multi-organ failure. This is what we observe in the sickest of patients who have the worst prognosis. And it's really unclear to what extent the thrombocytopenia is contributing to poor outcomes in these patients versus a marker of severe illness and organ failure. I also wanted to comment on the severity of the thrombocytopenia and the presence of thrombosis, as both of these features can be potentially helpful to figure out what's going on with your patient. I'm highlighting the severity of thrombocytopenia because platelet counts less than 20 have a very limited diagnosis. Profound marrow failure can cause this, but I would also expect a low reticulocyte count and an associated neutropenia in this situation. Overt DIC can result in severe thrombocytopenia, in which case you'd expect hypofibrinogenemia and elevated D-dimer levels. Antibody-mediated causes of thrombocytopenia can also result in severe thrombocytopenia, which include drug-immune, post-transfusion purpura, or ITP. HIT, interestingly, just to make things complicated, characteristically results in a DIR less or greater than 20. And lastly, HLH can result in severe thrombocytopenia, although in this case we would expect that there'd be a markedly elevated ferritin level. Thrombosis and thrombocytopenia classically occur in very specific instances, which include HIT, DIC, antiphospholipid syndrome, and ischemic liver injury with venous gangrene. By considering the past and the present, this can inform treatment, prognosis, and the estimated time frame for recovery for our patients. As is usually true in most instances, treatment is directed at the underlying cause. By highlighting the common platelet trajectories, we can also anticipate when thrombocytopenia typically recovers and sometimes identify patients who are behaving atypically. For example, in sepsis, improvement is not expected until 2 days after liberation from pressors. In patients who receive chemotherapy, it can take up to 2 weeks to see recovery, particularly in critically ill patients. After major surgery, the platelet count generally begins to rise 3 to 4 days postoperatively. And in patients on assist devices, thrombocytopenia is likely to persist until device removal. So how do we support thrombocytopenic patients? The risks and benefits of platelet transfusion in this setting are unknown, and the effectiveness of platelet transfusion to prevent major hemorrhage, reduce transfusion, and improve clinical outcomes is uncertain. Yet the harms associated with platelet transfusions are well documented, and they include nosocomial infections, thrombosis, and acute lung injury. High-quality trials really are needed. In the meantime, Here's a practical table that highlights common platelet transfusion thresholds. In a severely bleeding patient, generally expected. In a patient who isn't bleeding and who doesn't have planned procedures, we often don't need to transfuse unless the platelet count drops below 10. Otherwise, thresholds depend on the specific procedure. Generally, platelet thresholds range from 20 to 50, with the exception of intracranial bleeding or neurosurgical intervention. So I'd like to conclude by stating that thrombocytopenia in the ICU is common and largely correlates with adverse prognosis, but may independently contribute to poor prognosis. Multiple mechanisms may contribute to the thrombocytopenia, and differentiating the pertinent cause or causes in individual patients can be challenging. By looking back at the patient's medical history or their presenting illness, and by observing the platelet count trajectory in its clinical course, this can often provide clues as to the diagnosis and the prognosis. Thank you.